class, welcome back to Unit 1, Part 2. I apologize that the first part went a little bit long, so I wanted to break this up into two sections. So in this second section, we're going to talk about how to manage patients with oral and esophageal disorders. So let's first just review the role of the mouth and how important it is in our general health. So we've already talked about how digestion begins in the mouth and the breaking down of food and mixing it with the saliva and those oral enzymes. Diseases of the mouth interfere with communication. They can affect people's ability to take in adequate food and fluid safely. It can also jeopardize their general health. Oral problems do not stay localized to the mouth. They can have consequences systemically that we're going to touch base on the next slide. But the severity of the importance of good oral health is a lot of time overlooked. And what we need to teach patients, especially if they present with a problem in the oral and it seems like they maybe are have a deficit in the knowledge of how to care for their mouth, we want to provide them with prevention education. So things like going to routine dental care, and ideally it should be every 6 months, and then they should be using a toothpaste that has fluoride in it. They should be drinking from the community water resources because we add fluoride to our general water. They should stop smoking and minimize alcohol use. A good diet is important. And then manage any systemic diseases. So if they have hypertension, make sure they're taking their meds as they're supposed to, watching their sodium intake. All these things come together for good general health practices. So what if they've got a problem? Periodontal disease is super common in the general population, and here in America, dental care is very expensive, and so a lot of people will forego this. So periodontal disease is the most common cause for people to lose their teeth. And teeth are incredibly important in the beginning of the digestion process, but a lot of people just don't have a choice other than to get that tooth pulled, and then they may or may not be able to afford to get it replaced. There's two terms on the slide, gingivitis and periodontitis, self-explanatory as listed on the slide. Anything that ends in itis has an inflammation. Prolonged inflammation is never good. You can get infection, and we need to, educate people to take care of those problems in a timely manner, if at all possible. Who's at risk for periodontal disease? Older adults, people that smoke, people of lower socioeconomic status, and people that haven't had a great deal of education just because of knowledge deficits, and then resource limitations. If they're having difficulty affording food and a place to live, chances are dental care isn't high on their list of things that they can tackle at this time. And we need to educate these patients, clients, however you like to refer to them, that these periodontal diseases are connected to systemic diseases. They can make cardiovascular disease worse, diabetes mellitus worse, rheumatoid problems worse. So we need to treat these actively. So if you've got periodontal disease, it can cause periapical abscesses, so a tooth abscess. There can be an acute or a chronic. Acute is usually it comes on quick. Chronic is it's slowly progressive. Basically, you're going to have this pocket of pus, and the body's going to try to contain it for as long as possible, but usually it's incredibly painful. If it isn't able to contain it, the body, it could progress to cellulitis, so infection in the tissues. They could have facial edema, fever, malaise. It can really become quite serious. People it can progress to a systemic infection. There are medical things that we can do for people that present. So sometimes people will come to the hospital with a tooth problem, and the medical doctors will do an aspirate, maybe put an opening in to drain it, may offer them antibiotics, and the nurses have a role in that, just to be aware of that factor. Moving outward, we could have problems with the jaw, and we need to take these issues seriously. TMJ is a really prevalent problem. You could also have like degenerative joint disease, fractures, abnormalities, those sorts of things. So that's something to take into consideration. And then maybe we need to do a nutrition assessment if they have some of these issues. The other thing that we want to be aware of and assessing for is oral cancer. Unfortunately, in the early stage, it doesn't have a lot of symptoms. It could present as a painless sore or mass, or an ulcer with raised edges. It could have a red or a white patch looking. And that's another reason why dental care on a routine basis is so critically important, because your dentist will assess your oral mucosa for these types of problems so that we can catch it early. So if it progresses, they could have the complaints that are listed on the slide, and we need to take that seriously. Not just think that, it's probably just a bad tooth, but we have to worry about that it could actually be cancerous in nature. So just be sure that you're keeping that in the back of your mind as a possibility, especially people that smoke. Unfortunately, they're the ones that are really high risk. Okay, so we've talked about the oral cavity. Let's touch base on the mucous membranes. So having intact, healthy mucous membranes is very important, and these are things that we can do to help keep that from progressing or prevent impairment to begin with. Dry mouth is an issue that I want to talk about. So the saliva in our mouth helps control bacterial populations in our mouth. So dry mouth is a big problem because that will allow bacteria to grow unchecked. And so making sure that we keep adequate hydration, we provide oral care. And in this instance, I'm thinking of people that are NPO, people that have an NG tube, people that are on a vent, people that are getting frequent nebulizers. All of these patient populations, you have to think, hey, are we doing what we should to provide good oral hygiene to this patient while they're in the hospital? Because unfortunately, being in the hospital can cause complications and additional problems. And bacteria that's in the mouth can travel down the esophagus. If they have any sort of aspiration risk, they could actually get into the lungs and cause pneumonia. So it's all kind of interrelated and interconnected, and we have to take good care of it. So as a staff nurse, you want to be thinking, have I provided oral hygiene to this patient who's at high risk for impaired oral mucous membranes on my shift? So ideally, it should happen at a minimum once every shift. Okay. Moving forward, sometimes we've got to do surgery. So maybe they do have oral cancer and it's spread down to the cervical lymph nodes, and we need to remove that and contain the cancer. That can be a radical neck dissection, or there is also a modified one. And the big thing is that this is very risky because you're dealing with the airway. So anytime that we go in and we do surgery, there's going to be swelling because our body will have an inflammatory response and send the needed nutrients and immune system response to heal that area. And anytime you have swelling in the neck, you've got a risk for impaired airway. So that's a high priority assessment in someone that's had a radical neck surgery. Maybe they're ending up with a trach, maybe, hopefully not. Maybe it's going to be a temporary trach. Maybe we need to do frequent suctioning. So these are all things like, do we have a backup airway? Do we have suction set up in the room so that if something happens, we're already ready to go? These are the thought processes you should have as a nurse. So again, can't highlight it enough, maintaining that airway. We want to do a frequent assessment, watching for those early signs and symptoms that things are deteriorating. We don't want to wait for things to get bad before we take steps and notify the healthcare provider. We want to keep them in Fowler's. We want to encourage them to cough and deep breathe, because this is so important, because when people are in pain, when they don't feel well, they're not breathing as deeply as they normally are. And so that can allow fluid to accumulate on those alveolar sacs, and that can progress to atelectasis, which can progress to pneumonia. And by encouraging the patient to cough and deep breathe several times on your shift, that forces them to open those airways fully and clear those secretions. If your patient does have a trach, we need to provide trach care, which you've learned about last term. And then we need to provide good patient education about how to take care of that trach, signs and symptoms that they need to be suctioned, how to change the trach ties, all those sorts of things. This next slide is, I just wanted to throw out some terminology and plant some seeds of things that can cause problems in the esophagus. So achalasia is the term we use for when food gets stuck in the esophagus. We use dysphagia, that word, a lot, and it's most commonly used to describe difficulty swallowing foods or liquids. Things that can cause these problems are hiatal hernias, diverticuli, if they have a perforation, a hole in the esophagus, if they swallow a foreign body, if they have a chemical burn, and that can be an inhaled chemical burn as well. They have GERD, Barrett's esophagus, tumors, carcinomas, that sort of thing. So let's touch base on hiatal hernia. So hiatal hernias are those hernias that go through the diaphragm, and there's a sliding one, and then there's a rolling one, and this picture just shows you where the problem lies. So in A, you can see part of the stomach and the esophagus, and then in B, you've got the esophagus coming down and then a separate section for a herniated portion of the stomach. And we're going to talk about those in more details, but this is why they're at a problem or at a risk for esophageal issues, because the stomach isn't staying where it's supposed to be, and that means that the stomach contents aren't staying where they're supposed to be. Anytime, and we do a surgical procedure called a fundolipication to try and repair these problems. Anytime someone is having an esophageal, a radical neck, a hernia repair, any type of abdominal surgery or respiratory surgery, we need to assess them for crepitus and be aware that there's a risk for air to leak somewhere where it's not supposed to be, and this is a medical emergency. So crepitus is one of those words that has a couple of different meanings. It is like a grating, crackling, popping sound, and that is most commonly seen in the joints, like if someone has arthritis and you move their knee and it's kind of like this grinding sensation. That's an expected finding if someone has arthritis. When it isn't an expected finding is when it's a crackling sensation due to the presence of air in the subcutaneous tissue. And so that is a sign that air is leaking out of the lungs someplace where it's not supposed to be. And so that patient is at high risk for inadequate oxygenation. And this picture of this fellow shows you he has subcutaneous emphysema in the neck, the shoulders, and around his face. And if you were to palpate his skin, it would feel like Rice Krispies were underneath it. So ideally, we would be palpating and catching it early before it progressed to something like this. So that's why if you notice subcutaneous emphysema, you touch it, feel that Rice Krispie, stay with your patient and notify the healthcare provider that you may be having an air leak, okay? Super important. Let's see. I just remembered something that I wanted to touch base on. So I apologize. I'm going to back up to the previous slide for just a second. So because with a hiatal hernia, you have a portion of the stomach is on the wrong side of the abdominal cavity. This is why we assess the abdomen visually, and then we also palpate. A red flag of immediate concern is if your patient has a firm and distended abdomen, because this can be an emergency type situation where the part that is on the wrong side is actually not getting adequate blood flow and perfusion. Anytime you have a patient that has a firm and distended abdomen, you want to potentially think, is this a red flag? Is this something I need to report to the healthcare provider immediately? Because they may need emergent surgery, because if something isn't getting adequate blood flow, tissue death is starting to occur. And tissue death is not good, and it's only reversible if we fix it quickly. The other thing I wanted to touch base on is treatment for these hiatal hernias are very similar to GERD. What we do is we treat them with antacids, histamine 2 blockers, and proton pump inhibitors. And then keeping the head of the bed elevated is really important in this patient population. So I apologize, I just overlooked touching on that. So getting back to crepitus, I think we touched about that. So let's move on to the next slide where we talk about GERD. GERD is a very common disorder, and basically what's happening is the stomach contents, which includes hydrochloric acid, is going back up into the esophagus. And while the stomach is specifically designed to tolerate hydrochloric acid and an acidic environment, the esophagus is not. So it causes an injury to the mucosa in the esophagus. Early diagnosis and treatment of GERD is critically important to prevent it to progress into something called Barrett's esophageal or esophageal cancer. And this is the mechanism behind that. So if you've got something irritating tissue, the longer that irritation goes on, it allows your body is going to start doing cellular changes to try and protect it. And with cellular changes, sometimes things can go awry and it actually develops into cancer. So that's why there's that increased risk. There are people that are at more of a risk for GERD, and there are people that, one that I want you to think of is if they have an NG for a prolonged period of time, and I'm thinking like 3-4 days or longer, because that NG goes down through that sphincter and it impedes it from closing completely. So that allows the possibility of reflux to occur, and that's why it's important to keep that head of the bed elevated. People that are obese are at an increased risk because of that increased abdominal pressure. Smokers, people that eat diets rich in fat, people who drink a lot of alcohol, and people that are getting morphine for treatment. The morphine may be needed, and the thing is that the morphine changes the pressure differences and makes it a little bit easier for a reflux to occur. So what are the signs and symptoms that your patient has GERD? Because early diagnosis and treatment is important. They could complain of burning epigastric pain, heartburn, which can be mistaken for cardiac pain. And that's another reason why it's important to seek help early and not self-treat, because what you think might be a stomach problem could actually be a cardiac problem. So we do typically rule that out first. They can also complain of nausea, bloat, cough, hoarseness. Their problems may feel worse after eating or when lying down. They could say they have a feeling of fullness all the time or a feeling of fluid in the back of the throat. We are going to monitor these patients very closely for aspiration, especially if they have an episode of regurgitation. We're going to keep the head of the bed elevated, and we're going to auscultate those lung sounds on a regular basis. One of the tests they can do is a barium swallow. They can do 24-hour pH testing. They could go in with a camera and do an endoscopy and just look and see what's going on. If you notice coughing or sputtering when eating or drinking, know that these patients have an increased risk for Barrett's esophageal, which is a kind of a stricture or narrowing of the esophagus. What do we want to tell these people to do to take care of themselves? Well, they should eat 4 to 6 small, frequent meals per day. If they're overweight, they should try and get some weight loss. They're going to use antacids, histamine 2 blockers, proton pump inhibitors, and cholinergics. Cholinergics work by increasing the lower esophageal pressure, making it less likely for things to reflux up. We're also going to tell them don't lie down after a meal, avoid eating acidic foods, and stop smoking. If they're still symptomatic, they may need their proton pump inhibitor twice a day instead of daily. And proton pump inhibitors anymore are the go-to medications, and those are things like omeprazole for long-term treatment because they just work better. They're more effective at reducing stomach acid than histamine 2 blockers. So I think we've already talked about that. Yep, I think we've hit all that. So we'll go and just keep moving forward to the last section, and that is patients with obesity. Okay, so obesity is very common in the U.S. and more so worldwide. Over half of Americans are overweight or obese. The causes are complex and multifactorial. There are behavioral, environmental, physiological, and genetic components. So there's no easy one fix for this problem, which is what makes it more difficult to treat. We do need to treat it though, because obesity is associated with anywhere from 6 to 20-year cutoff, a decrease in life expectancy. So these people are going to live longer than their regular weight peers. With an increased body mass index, there's also a corresponding increased risk for cancer. The likelihood of developing type 2 diabetes is times 10. Asthma or hypertension is times 4 more likely. And these patients are twice as more likely to develop Alzheimer's in their lifetime. So the bottom line assessment or baseline assessment is the body mass index. So this is just a rule of thumb. It's a guideline, not a hard and fast rule, and it's most helpful when trended over a period of time. So we use the height and the weight, and the general categories is if it's 25 to 30, you're just overweight. If you're greater than 30, you're obese. If you're greater than 40, severe or extreme obese. Another resource we have for assessment is the waist circumference. There is a greater risk for obesity if women have a waist circumference greater than 35 or greater than 40 in men. We can also take a look at their hip to weight ratio. And then there's laboratory studies, your cholesterol levels, triglyceride, fasting blood glucose, hemoglobin A1C, liver function tests. All of those can help as well. So our role in obesity management is to know what are the resources and then to also work with the client to help identify goals. So lifestyle modifications are aimed at weight loss and maintenance, setting weight loss goals, improving diet habits, increasing activity, addressing any barriers that the patient has to making change. Educate and support self-monitoring, strategizing lifestyle changes, encouraging healthy sleep habits. We can turn to pharmacological methods. Anti-obesity medication is meant to supplement, not replace diet modification and exercises. There are non-surgical or minimally invasive procedures that we can do, or we could do surgery as well. Management, we need to approach these people respectfully, courteously, and have empathy because this is a very challenging condition to treat successfully with long-term success rates. They are at risk for hypoventilation, increased intra-abdominal pressure, increased moisture and friction. They're at risk for impaired mobility, for impaired skin integrity and body mechanics. And we need to make sure that we use bariatric equipment to keep these patients safe with positioning. For ventilation and circulation, we're going to keep these people in low Fowler because it's easier for them to breathe that way. We're going to take a close look at those pulse oximetry. These patients, if they do have a surgical intervention, they are at risk for inadequate oxygenation. They may even have sleep apnea and need a CPAP. When we're assessing them, we need to make sure that we're using an appropriate blood pressure cuff size and know that these people are at risk for a deep vein thrombosis, so early ambulation is very important. There are some pharmacokinetic and pharmacodynamic issues that we need to be mindful of, is that drugs may have a slightly different effect on them because their body composition is different. And some drugs that are weight-based calculations may not be truly weight-based because we top it out. For example, Lovenox. Lovenox is an anticoagulant used frequently post-surgically to reduce the risk of deep vein thrombosis, but there's a maximum dose. So if your patient weighs 400 pounds, the weight-based calculation may not be appropriate because it may be too much medication. So we need to be cognizant of that. Bariatric surgery, it results in weight loss, usually about 10 to 35% of their body weight within 2 to 3 years. It does show an improvement in the core morbidity problems that are associated with being obese. Candidates are selected by a multidisciplinary team. It's not for everyone. There are risks, there are benefits, and you have to be an appropriate candidate. Surgery is usually only performed after non-surgical weight loss methods have failed. And a very common one is the Roux-en-Y gastric bypass. They can also do a gastric band, they can do a sleeve, they can do a diversion, and these can be performed laparoscopically or by open surgical technique. Ideally, it would be performed laparoscopically because laparoscopically has fewer complications and a shorter recovery time than an open procedure. Preoperatively, we need to educate the patient and provide counseling about the risks and benefits of surgery, complications, what to realistically expect post-surgically, what are the dietary changes that are going to have to be made and be permanent, and what is the lifelong follow-up, because all these carry risks and lifestyle modifications to be successful, and frequent lab testing as well to make sure you're getting your nutrient needs met. This is a picture of a Roux-en-Y gastric bypass. So basically they make a little pouch out of part of the stomach. The rest of the stomach just becomes not used, and then they reroute the jejunum to the pouch. So the duodenum is not being used anymore. And if you remember from our first part, the duodenum is where we get a lot of our nutrients. And so that's why these patients need to have lifelong follow-up to make sure their nutritional needs are getting met. Patients that have had a stomach surgery are at risk for a dumping syndrome. And dumping syndrome is a rapid emptying of food from the stomach into the intestine, which can cause abdominal distension within 30 minutes of eating, vertigo, tachycardia, syncope, sweating, pallor, palpitations. It's not a good feeling. Basically, it's like everything is just rushed out of your stomach and your body is like, what the heck is going on? And like I said, anybody who's had any kind of stomach surgery is at risk, and this can develop up to 2 to 3 years after the surgery. This picture is a banding picture. So basically, there's just a little band around the stomach which creates a little pouch, and then the food stays in that pouch and gives the patient a sensation of fullness for longer. This surgery doesn't have the nutritional deficit risk. After a bariatric surgery, we want to keep the following ideas at the forefront of our mind. Abdominal binder prevents wound dehiscence. Remember that if you have a wound dehiscence, the immediate response is to put a sterile, moist dressing over the site and notify the healthcare provider, because they're going to have to go immediately to the OR and have their stomach resutured. Positioning, keep them in semi-fowlers. Make sure they've got an open airway. Make sure they've got good oxygen saturations. We're going to use all the resources that we have: TED hose, SCDs, heparin or Lovenox for DVT prevention. Skin assessment, we're going to be looking for moisture, friction, that sort of thing. And we want these people up and moving as soon as possible post-surgically, keeping a close eye on their abdominal girth for how it's trending over the period of time. And then use appropriately sized equipment, bariatric equipment. Okay, this slide just kind of hits up what I already said about dumping syndrome, getting the patient up, that sort of thing. Okay, that brings us to the end of part 2. Thank you so much for listening, and I will see you in class. Thank you.